It's my pleasure here to talk about management strategies in radiation heart disease. Before we talk about the management, I think it's important to acknowledge the scope of the problem. There's an epidemic of global cancer. Cancer rates are increasing everywhere. And radiation therapy is a cornerstone of cancer treatment. And as a result, an estimated 50 million people worldwide have received thoracic radiation alone. At its inception back in the 1940s, it was thought that the heart is the prototype post-mitotic radio-resistant organ. So initially, there was really no concern. They would give as much radiation dose as possible. But this paradigm actually shifted, and now the heart is considered the most critical dose-limiting organ in radiation therapy. All cardiac structures in field of radiation are at risk. The main culprits are breast cancer, Hodgkin's disease, and lung cancer in that order. The relative risk of fatal MI is variable according to the underlying cancer and radiation dose. In Hodgkin's disease, it could be as high as 8.8. In left-sided breast cancer, it's 2.2. There's a wide spectrum of cardiac complications, ranging from coronary stenosis to a variety of pericardial syndromes, valvular disease, cardiomyopathy, and conduction system disease. And the problem is that sometimes these patients can have more than one problem, and that can increase their risk and complicate their management. Some of the factors which increase cardiovascular risk in mediastinal radiation are patient-driven. They include associated concomitant anthracycline chemotherapy, the proximity of the tumor to the heart, younger age, associated traditional coronary risk factors, baseline cardiac disease, and interval time from the index radiation exposure. Then there are technical radiation-related factors. Chief amongst them are total dose to the heart. So the risk of radiation injury to the heart increases exponentially once the cumulative dose is more than 30 grays. And also the daily dose fraction of more than 2 grays per day is associated with increased risk. So recognizing this, back in the 1980s, there was a switch to what we call so-called modern era radiation treatment, which emphasized on the importance of localizing the treatment, providing proper shielding, and limiting cumulative doses. And that has translated into better outcomes. The relative risk for fatal MI over time has decreased. In the 1940s, it was around 6.3, and according to some estimates in the 1980s, this was down to 1.6. Let's talk a little bit about each individual problem. So as far as coronary stenosis is concerned, there's a long latency period. There's a wide range between 3 and 30 years. The risk increases after 5 years, and it becomes really steep after 10 years. Now, with that very long latency period, it's often difficult to establish causality because coronary disease, which is conventional coronary disease, is also very common. However, clinical observation of premature coronary artery disease in young patients who don't have risk factors post-radiation and also animal models now firmly establish that there's a causal association between the two. Now, these lesions may start for different reasons post-radiation as opposed to conventional atherosclerosis, but as they mature, they resemble atherosclerosis to a great extent, with the caveat that radiation-induced coronary artery disease has higher component of fibrosis to lipid ratio. Traditional risk factors accelerate the disease, so it's extremely important to identify risk factors early on and aggressively treat them. The overall incidence is estimated to be 5.5 to 12%. This is for radiation-induced coronary artery disease, and this is based on literature from the Hodgkin's population. There are angiographic features that are characteristic for radiation-induced coronary artery disease. These lesions tend to be more ostial or proximal in their distribution. The involvement of the coronary tree depends on where the site of radiation is. So if it's mediastinal radiotherapy, the left main LED and RCA are susceptible. If it's left-sided chest radiation, as in left-sided breast cancer, then LED and to a lesser extent left main are susceptible. Note that the circumflex, because it wraps around behind the heart on the left side, is least prone to radiation-induced injury. On average, these lesions are longer and more tubular compared to conventional atherosclerosis. So this is an example of a patient who, with Hodgkin's disease who received mediastinal irradiation 19 years earlier, and then she presented with classical angina and underwent coronary angiography. You can see the panel on the right showing a very tight proximal RCA and a distal left main on the panel on the left. Now, if you take out the history of irradiation, these lesions would be identical to bread and butter coronary atherosclerosis. This often also gives rise to certain complex decision making as well. So this is an example of a 60-year-old female who received radiation therapy for advanced non-small cell lung carcinoma. And 8 years later, she presented with stable angina, positive exercise stress test, undergoes coronary angiography, and showing a very tight ostial left main. Now, her clinical syntax score is estimated to be 12% in the intermediate range. Her Euro score is very low. So she's approached by the surgeons and the interventional cardiologists. The surgeons say that your operative risk is very low. The type of lesion you have, you should receive coronary artery bypass surgery. On the other hand, the interventionalists say that this lesion is amenable to PCI, and you have had radiation therapy to your chest, so your surgical risk is going to be higher. So what to do? Well, let's go back a little bit and see where each camp is coming from. We talked about the proximal osteal distribution of the disease, the multivessel nature of this disease, which may favor coronary artery bypass surgery. Non-coronary disease issues can also be concomitantly addressed when bypass surgery is offered. Remember, a lot of these patients will have pericardial involvement. They can have significant valvular disease, so those issues can be addressed as well. But there are limitations for bypass surgery. For example, substernal scarring and mediastinal fibrosis may lead to a lot of dissection, and going through the adhesions may cause a lot of bleeding, and that could increase the perioperative risk. There could be associated pulmonary dysfunction from radiation injury. And the internal memory arteries are also sometimes affected by radiation, so they could be friable, difficult to suture, and they could be prone to premature closure. In fact, the issue of IMA suitability as a surgical conduit has been an area of debate in this patient population. Anecdotes and case reports have highlighted that sometimes these conduits are not usable. Case reports and case series beyond that have provided mixed data. Some of them have suggested that this is an overblown issue, while others have suggested that anywhere between 30 and 50% of patients do not have conduits that are suitable for use as bypasses. Regardless of this debate, however, this is a true problem, and experts advocate that screening of the grafts should be undertaken at the time of conventional angiography, or if that wasn't done, then CT coronary angiography can provide a suitable way to evaluate these grafts. So the question then becomes, if there are potential issues with surgery, do they actually translate into poor outcomes, and has that ever been documented? The data is very limited, and most of these are retrospective case series because it would be ethically impossible to do a randomized trial. But this is one of the largest case series of 173 subjects who underwent irradiation. 53% of them had breast cancer, 27% had Hodgkin's disease, and they were compared to an age and gender matched cohort of patients who did not undergo irradiation. And the survival after bypass surgery was compared, and you can see on the panel on the right that there was a divergence in the survival rates very, very early on, even within the first 6 months. And this sort of highlights that this is probably not related to their underlying malignancy to have this sort of divergence early on. Radiation history was an independent predictor of survival. And the serious issue here is that whatever risk scores were used, whether it was STS or Euroscore, they consistently overestimated survival in these patients because things like adhesions in the chest are obviously not taken into account when these scores were developed. What about the PCI camp? Well, these lesions can be discrete, and they can be appealing targets for PCI. PCI can be a feasible option in low to intermediate complexity CAD. We think that their procedure risk is going to be lower versus CABG, although there is no data in this particular population to support this. Now, the problem with PCI, and this was raised by one study looking at angiographic restenosis at 6 months, in about 15 patients, small numbers again. What they realized is that the rates of restenosis are far higher than controls who underwent stenting with BMS. So 86% versus 26%. It's very disappointing, unfortunately, that despite having more than a decade of experience with drug-eluting stents, there is no robust data beyond case reports on long-term outcomes with drug-eluting stents. And one would imagine that drug-eluting stents are going to be a perfect option for these type of patients. So back to the question, PCI or CABG? Well, unfortunately, there are no specific guideline recommendations for radiation-induced CAD. The mode of revascularization should be guided by appropriateness criteria for revasc, but they should further be individualized based on patient-specific factors. The other issue is that estimating operative risk in individual patients should consider additional factors that are not accounted for by the risk scores. And also, always don't forget to screen for the IMAs if bypass surgery is being advocated. Okay, so back to our case, the 60-year-old female who had radiotherapy 8 years earlier and is now in remission, who has been offered bypass versus PCI. The patient goes for bypass surgery, and what happens is that she has severe bleeding secondary to adhesions, and she actually dies. So this sort of highlights again that decision-making in these patients can be quite complex. Now, beyond this, there are other therapies which are under investigation. Currently, ACE inhibitors and statins are being looked at thoroughly. The underlying mechanism of radiation-induced CAD has not really been elucidated very well. No one really knows why, after initially receiving radiation treatment, does the process continue for so many years. Now, a couple of animal studies have been bringing us a lot of new novel information, including the fact that the inflammatory cascade is upregulated, and one of the key mediators perhaps is nuclear factor kappa B. And now there are nuclear factor kappa B inhibitors which are under investigation for other uses, and perhaps it's possible to maybe see a clinical study in the future looking at the utility of these agents in patients with radiation-induced CAD. Okay, so let's switch gears and talk a little bit about pericardial syndromes and acute pericarditis. So this used to be a very common problem in patients with Hodgkin's disease who, like we said earlier, used to receive high doses of radiation. With modern radiation techniques, the incidence has dropped from 20 to 2.5%. The clinical presentation is very similar to viral or idiopathic pericarditis. The most recent European guidelines on pericardial diseases do not provide any specific recommendations for radiation-induced acute pericarditis. One needs to be cognizant of the fact that about 10 to 20% of these patients will go on to develop chronic pericarditis, and it's feared, the most feared sequel of that is constrictive pericarditis. Looking at the autopsy data, 70% of patients at autopsy have evidence of injury, meaning that a vast majority of these patients are not going to have clinical disease. So the European guidelines emphasize on the use of conventional therapy for acute pericarditis, and that would be applicable to patients with post-radiation acute pericarditis as well. So you can use intermediate to high doses of aspirin or other non-steroidal inflammatory agents for 1 to 2 weeks with a tapering regime. Recently, there has been a lot of interest in the utility of colchicine as an anti-inflammatory agent, and a couple of these trials have come out of Italy, culminating with the ICAP trial that was published in 2013. And this study looked at the utility of colchicine as an add-on agent to aspirin or non-steroidal anti-inflammatory agents after a first episode of acute pericarditis. And the primary outcome was incessant or recurrent pericarditis. And this study, along with the previous ones, showed that the addition of colchicine actually reduces these primary outcomes significantly by about 50%. And that has left a mark on the guidelines. The guidelines have endorsed the use of colchicine and given it a Class 1A recommendation as an add-on therapy to aspirin and non-steroidal agents for about 3 months, with doses varying between 0.5 milligrams per day to 0.5 milligrams twice a day, depending on the patient's weight. Does that apply to patients with radiation-induced pericarditis? Well, all the clinical trials that I showed to you before did not include patients with radiation pericarditis. They included patients specifically with viral or idiopathic pericarditis, post-cardiac injury, and connective tissue disease. They did not specifically exclude patients with radiation pericarditis, so it is reasonable to assume that those recommendations can be extrapolated to this population as well. What if the patient goes on to have chronic pericarditis or recurrent pericarditis or any type of pericarditis that is refractory to medical therapy? You can then use second-line agents, which include low-dose corticosteroids. The third-line agents, I'm not sure if that would be applicable to this population because they're immune suppressants, and as a last resort, pericardiotomy can also be offered. So there are other syndromes, including tamponade and pericardial effusion. So asymptomatic pericardial effusion is the most common pericardial syndrome. Spontaneous resolution is common, so this tends to be an incidental finding most of the time. If there is an effusion that is large enough to cause hemodynamic compromise, then it is treated with pericardiocentesis. If it is recurrent or persistent, then, and it is causing hemodynamic compromise, then pericardial window can also be offered. If the patient goes on to develop the most feared complication, which is constrictive pericarditis, then pericardiectomy should be offered, knowing, however, that these patients have a high risk because of the adhesions and the associated cardiomyopathy that they may sometimes have. Okay, what about valvular disease? So the valves can similarly be affected. There's a long period of latency of more than 20 years. There could be fibrotic thickening, retraction, and calcification of the valves. Left-sided valve lesions are more common, most likely because of the increased hemodynamic stress. And in the beginning, the first 10 years, some studies have elucidated that a lot of these patients tend to have regurgitation as a primary lesion. About 40% of patients can have asymptomatic moderate regurgitation, but then later on, stenosis becomes a predominant pathology. What about outcomes of valve repair if a patient is a candidate for valve repair? Well, there's one case series from the Mayo Clinic looking at outcomes for 22 subjects who underwent valve repair. 32% of these patients had early severe dysfunction and 16% required reoperation by 1 year, which are not very optimal outcomes. So experts advocate that valve replacement should be the way to go. Now, there are two methods for valve replacement, conventional surgery versus minimally invasive procedure. So maybe one should have a lower threshold to employ minimally invasive techniques such as TAVR or whatever other techniques might be coming up later on. Now, cardiomyopathy can also be seen. The vast majority of patients with radiation-induced injury will develop diastolic dysfunction and preserved LV systolic function, but sometimes they can also develop systolic dysfunction. The problem is that this population is not well represented in randomized clinical trials of evidence-based therapies for LV dysfunction, but treatment should be offered according to the heart failure guidelines. If an ICD is indicated and the patient has a survival of more than 1 year, sometimes there could be significant subcutaneous damage and poor wound healing, so a subpectoral ICD implant may be required. Now, advanced heart failure therapies like assist devices or cardiac transplantation could be offered, but the patient has to be cancer-free. There should be extensive discussion with the patient and the oncologist about their cancer-free survival, which is estimated survival, and these therapies could be offered on a highly selective basis. The outcomes, however, are not that great. As expected with cardiac transplantation, this is associated with high risks of early death, severe infections, and second cancers as well. Terminal cancer patients, on the other hand, who are not candidates for any of the advanced therapies, we need to go the other side of the pendulum, and sometimes we need to back off on treatments because the emphasis should be on quality of life rather than longevity. Lastly is conduction system disease. This is the least common consequence of radiation-induced heart disease, with a latency between 1 to 23 years, an average of 12 years. There's a wide spectrum of electrical abnormalities that can be encountered, ranging from benign first-degree AV block, isolated right or left bundle branch block, all the way to complete heart block. And these are unusual to occur in isolation. When they happen, particularly the more extensive the presentation, the more likely that it's a marker of myocardial fibrosis. Management, however, is as per guideline recommendation, as there are no specific consideration as far as permanent pacemaker implants are concerned. So to conclude, there's a wide spectrum of cardiac complications from radiation therapy. Increasing cancer rates require effective prevention and treatment. And that is better. I mean, prevention is always better than treatment, obviously. Outcomes with drug-eluting stents for radiation-induced CAD should be formally tested. And optimal intervention is an individualized decision based on a thorough risk-benefit assessment. Thank you very much.